It's my honor and privilege, someone that I look up to and try to run my practice in a similar process of trauma being the root of addiction, mental health, and many of the chronic pain. Dr. Gabor Mate.
Thank you. Thank you, Robert. It's a pleasure to be here. So I thought I would divide my presentation today into three parts, really, three themes. The theme of this conference I understand to be chronic pain. And so chronic pain shows up in chronic health conditions that cause pain, such as autoimmune disease, rheumatoid arthritis, lupus, scleroderma, multiple sclerosis, and so on. It also shows up in many people who become addicted, and there's a real controversy, has been a controversy now over the role of opiates in treating chronic pain, given the addictive potential of the opiates. So it's important to understand addiction. And then thirdly, there are just chronic pain syndromes that are not attributable to any particular diagnosable disease. People just have chronic pain. So those are the three areas that I'd like to cover today: specific illnesses, the issue of addictions, and then chronic pain in general. Now, these are not disparate areas. In fact, in my view, they all have a common template, and that common template is childhood trauma, coupled with adult stress. And trauma and stress as sources of illness are not much attended to in medical practice, although there's a vast body of literature linking it all together. So what I'm talking about is that there seems to be a real science practice gap. And as much as we as physicians like to tell ourselves that we're practicing evidence-based medicine, sometimes I only wish that we did, because there's so much evidence relating chronic health conditions and chronic pain to trauma and stress that we're simply not following. And so that what is evidence-based is a very narrow definition, I think, of the evidence. Well, just how did I come to link all these things together? So I have to say that in family practice, I have an advantage as a physician over my specialist colleagues. I don't mean personally, I mean in general. And that is that we get to know people before they get sick, before they develop chronic pain, or any of the conditions that lead to chronic pain. We also get to know them in the context of their families. And we get to know something of their histories, their life histories. That is, if we ask them about it, which often we're not trained to do. But the difference then is that by the time a client goes to see a specialist, they've pretty well already been diagnosed, or at least the area or the organ system in the body that is being afflicted has been identified. And so the specialists just deal with the specific problem that the patients present without a background in the patient's life history or family context. So that's an advantage of following somebody through a family practice. And this is where I began to notice that who got sick and who didn't. And I'm talking about any chronic illness, whether autoimmune disease or malignancy, or chronic pain syndromes, or addictions. It wasn't accidental, but that there were certainly some personality traits and family history backgrounds that seem to predict, or at least be saliently present in people that develop these chronic issues. Let me give you a simple example. As a GP, you all often have to deal with people in the aftermath of car accidents, rear enders, fender benders. Now here in British Columbia, the Insurance Corporation of BC kind of set down pretty hard and fast rule that, you know, if the impact was so much, the speed of impact was so much, then you expected to have so much pain. And if your pain was out of proportion to the impact, then we simply didn't believe you that you have that much pain. And I was often struck that two people can have the same impact, but one of them will develop chronic pain, the other will not. The other will shrug it off, a couple of physio treatments, and it's over. And of course, the suspicion arises, is the first person with the longer period of pain after a similar impact accident simply trying to game the system? Well, that's always a difficult question, but as a GP who kind of knew my patients, that's not what my impression was. My impression was that people who reported severe chronic pain really did experience it, at least subjectively. And of course, pain is subjective by definition. And what I began to notice is that those patients of mine who develop chronic pain after relatively mild accidents, they had histories of childhood trauma. So then I started thinking, well, why would that be the case? And it occurred to me that there's a number of factors that might explain why people with histories of trauma would have more pain after a similar, objectively similar impact. Number one, people that experience childhood trauma, they may be more rigid in their body armor. They may be just more rigid in how they carry themselves. And it's like a straw. You know, if you bend a blade of grass, it'll rebound. But if you bend a hard object like a straw, it'll break. And of course, people with chronic childhood trauma will be more tense in their bodies. So that's the first, so that the impact would be greater on them. Number one. Number two, there's something similar about childhood trauma and being rear-ended, which is that out of the blue, for no fault of your own, unpredictably, and without your control, all of a sudden you're hurt. Now, the emotional imprint of that is in you. So when something happens in adulthood that's similar in a sense of emotional impact, that might trigger the pain. And, you know, when you're rear-ended, you have no control, you can't predict it, and there's nothing you could have done about it. You didn't deserve it. Same with childhood trauma. So there's an emotional resonance there. And then number three, typical of the histories of people with childhood trauma, childhood abuse, is that there was either nobody that they could complain to. And when I've talked to hundreds of people by now with, say, it's childhood sexual abuse. And one thing that's very common is you ask them, who did you talk to about it? The answer is nobody. In other words, they were emotionally isolated by the time the abuse happened, which actually was what made the abuse possible. Or if they did speak to somebody, they weren't believed. So somebody comes into my office, they have back pain due to a rear-ender, and I'm skeptical. I don't believe them. And the insurance company doesn't believe them. Guess what? Their memory of not being believed and being alone with their pain is triggered. That makes the pain worse. Those are some of my thoughts as I was looking at these patients. In other words, there's a tremendous interaction and interdependence between people's emotional histories, the emotions they carry in the present from the past, and then events that trigger all that emotional resonance from the past that occur in adult life. So that's just one little strain that I realized. More generally, I became aware that people who develop chronic illnesses, and I'm talking about autoimmune disease, chronic skin eruptions, malignancy, chronic asthma. It wasn't accidental. In other words, these weren't random events striking people as a misfortune out of the blue with no reason. And I'm sure he wasn't the first one to notice this. I wasn't the first one to notice it, but in a sense I was, because nobody had taught me about this in medical school, even though the research had already been published, that certain personality traits do seem to predispose to chronic illness. And these personality traits have to do with repression of emotion. So the more emotion repression there was, the more likely chronic illness was likely to show up. And repression is the pushing down of emotional pain beneath the level of consciousness. Suppression is another mechanism. Suppression, though, is a bit more conscious. So I may be angry with you, but because you're bigger and stronger than me, I may suppress my anger just out of self-protection. And that's maybe a smart strategy. However, if I'm doing it chronically, it's going to affect my physiology. Repression is even deeper than that when people are not even aware of the emotions. It's not that the emotions aren't there. They're just not aware of them. And so in my family practice, and then for 7 years, I was medical coordinator of the palliative care unit at Vancouver General Hospital. It's called Vancouver Hospital now. And this was Canada's largest in-hospital hospice unit, where we cared for terminally ill people, usually with malignancy, but sometimes with chronic heart disease, or rarely chronic autoimmune disease, and so on. And often, of course, pain control was a big issue that brought them to hospital, whether for palliation and respite care, or whether for terminal care. And what I noticed, both in my family practice and also in palliative care, well, in palliative care, you really get to know people, because when you sit there and you talk with people, you get their life histories. And of course, in family practice, if you spend time with people, you get to know their backgrounds and their family histories. And I noticed that there were certain traits that people had to develop chronic illness. And I will illustrate these traits for you by some brief newspaper clippings that I cribbed from the Globe and Mail newspaper. Those of you that are Canadians, the Globe and Mail considers itself to be Canada's national newspaper, and it's published across the country. I used to write a weekly medical column for them back in the 90s. And so these are clippings from the Globe and Mail. So the first one is by a woman who's developed breast cancer, and she's in the doctor's office. Her doctor's name is Hai, and her husband's name is Harold. And Donna, and this is a first person report. It's from a column in the Globe and Mail where people write in the first person about their own experiences. So Donna here is describing her diagnosis with breast cancer. Harold, the doctor, informs her of the diagnosis. So I'm going to quote what Donna says here. Harold tells me that the lump is small and most assuredly not in my lymph nodes, unlike that of Hai's first wife, whose cancer had spread everywhere by the time they found it. You're not going to die, he reassures me, but I'm worried about Hai. I won't have the strength to support him. Now, notice what happens here. So the husband's first wife died of breast cancer. Now the second wife is diagnosed with it. And the second wife's first thought is, how will I support my husband? So she's the one who's just been diagnosed with a potentially fatal illness. The doctor doesn't know. Can't reassure anybody because you never know when some metastases already happened. So he doesn't know. And she's the one who has to undergo treatment, chemotherapy, surgery, possibly radiation. And her first automatic thought is, how will I support my husband? So this compulsive regard for the needs of others while ignoring your own is, I'm telling you, a risk factor for chronic illness. And why should that should be the case? I'll talk about it later. The others are obituaries from the Globe and Mail. The Globe and Mail has a section called Lives Lived. And what's interesting about obituaries is that they often describe characteristics that I have found to be risk factors for illness, and not just I, by the way, but have been found to be a risk factor for illness. But these are presented as wonderful traits to be admired. It's kind of a sad irony there. So this is a physician who died in Toronto. He was 55, he died of cancer. This is what the article said. Never for a day did he contemplate giving up the work he so loved at Toronto 6 Children's Hospital. He carried on with his duties throughout his year-long battle with cancer, stopping only a few days before he died. So this compulsive identification with duty, role, and responsibility. I mean, if a friend of yours was diagnosed with cancer, I don't know, what would you advise them? Would you advise them to keep working? Never think of themselves. Don't take a moment to look at what, all the while they're getting treatment, don't take a moment to rest, to deal with stresses in their lives. Just keep on going. So this compulsive identification with duty, role, and responsibility, which, by the way, is very common in the medical profession, as I can tell you personally, is at the same time a risk factor for illness. The next characteristic has to do with anger. Now, in all manner of diseases, from fibromyalgia to amyotrophic lateral sclerosis to malignancy, the repression of anger has been shown to be a significant factor. And so here's an obituary written by an appreciative husband who says about his wife, who died of cancer, breast cancer, age 55. In her entire life, she never got into a fight with anyone. The worst she could say was phooey or something else along these lines. She had no ego. She just blended in with the environment in an unassuming manner. So the repression of, no, this niceness, never get into a fight with anyone, blending in with the environment in an unassuming manner. What are they about? They're about the repression of healthy anger. I always worry about these very nice people who never get angry because I think they're at risk, and they are at risk. There's the expression, the good die young. They do, or the chances are that they will. I'm not talking about not being kind or nice. I'm talking about if that niceness is a manifestation of repressed anger, that person is at risk. And this has been shown in a whole lot of conditions for reasons I'll explain later. And then I'll give you one more obituary here. This is a physician in Ottawa who died at age 72 of cancer. And again, the obituary is presented as something laudable and admirable. His name was Sidney. Sidney and his mother had an incredibly special relationship, a bond that was apparent in all aspects of their lives until her death. As a married man with young children, Sidney made a point to have dinner with his parents every day, as his wife Rosalind and their 4 kids waited for him at home. He would walk in, greeted by yet another dinner to eat and to enjoy. Never wanting to disappoint either woman in his life, Sidney kept having 2 dinners a day for years until gradual weight gain began to raise suspicions. So this man suffered from 2 fatal beliefs, and when I say fatal, I say so advisedly. One is that he was responsible for how other people felt, and 2, he must never disappoint anybody. Now, I said that all this is related to childhood trauma. What are we talking about here? These traits of hyper responsibility for other people's emotional needs, ignoring your own. rigid and compulsive identification with duty, role, and responsibility, repression of healthy anger. And there's a distinction to be made between healthy and non-healthy anger. And the beliefs that you're responsible for other people feeling, you must never disappoint anybody. These create stress, and stress leads to illness. By the way, I talked about healthy anger. There's unhealthy anger as well. Unhealthy anger, we know, is a risk factor for heart disease and cardiovascular illness, high blood pressure, and strokes. In the aftermath of a rage episode, a person's risk of having a cardiac or a cerebrovascular event doubles for the next couple of hours. So we have this three-pronged relationship to anger. There's healthy anger at one extreme, there's unhealthy anger at the other, and then there's repression of anger. And unhealthy anger and repression of anger both promote illness. Healthy anger promotes well-being. Healthy anger does. Now, what is the relationship of childhood trauma? And by the way, of course, a lot of these illnesses that people develop, like malignancy and autoimmune disease, people who have these traits, these conditions have chronic pain. How does this relate to childhood events? I'm going to be as succinct here as I can, and then I'll stop and take some questions. These character traits, which again have been studied by others and published, Dr. Lydia Timoshuk talked about the type C traits. She was mistakenly held to have said that there's a type C personality. These are not, those don't describe a personality. These are coping traits, character traits. They're coping mechanisms. But to cope with what? Well, here's the thing. In childhood, we have a fundamental need for attachment relationships. And incidentally, there's studies that indicate the relationship of chronic pain to insecure attachment styles. I'll say more about that later. But attachment is simply a drive to be close to somebody for the purpose of being taken care of, or indeed for the purpose of taking care of the other. So the great, and unfortunately deceased neuroscientist who died a few years ago, Dr. Jan Panksepp, very famous student of affective neuroscience, he delineated a number of brain systems that we share in common with other mammals, emotional brain systems, and he capitalized these. One of them was for care, C-A-R-E, and the care system is what instinctually drives us to take care of the vulnerable, particularly the young, but not just the young, the vulnerable. That's a system that's activated instinctually in our brain under the right circumstances. So we have this attachment system, and there are certain neurochemicals associated with it, particularly oxytocin and the opioids, the endorphins. We also have a system for healthy anger. He called that the rage, R-A-G-E system. And that's there to protect our boundaries, so that when somebody threatens to transgress our boundaries physically or emotionally, we mount a rage response. Stay out. That's healthy anger. The repression of it isn't just the repression of an abstract emotion, it's the repression of a whole brain apparatus with its particular neurochemicals and connections to the rest of the body. So we have this need to attach. That's non-negotiable in young childhood, because no infant, whether a bird or a mammal or a human, can survive without attachment relationships. We have another need, though, which is authenticity. And authenticity simply means being able to feel our emotions, because our emotions are there for a reason. They're there to protect us. In the wild, if you don't have your gut feelings at your disposal, you just don't survive. And by the way, we developed in the wild for millions of years, hundreds of thousands of years. And we lived in the wild until about 15,000 years ago. So that authentic relationship to our emotions was essential for survival. Okay, so we have these two needs: attachment, authenticity. What happens if the two come into conflict? What happens in a family where, say, the parents follow the advice of a lot of psychologists these days that an angry child should be punished? This is typical parenting advice: timeouts for an angry 2-year-old. What does the child learn? You know, the kid gets told, good little kids don't get angry. But that's not what the kid hears. What the kid hears is, angry little kids don't get loved. They get banished. Well, the child needs the attachment relationships. As a matter of survival, they'll suppress the anger. And now they're sitting duck for illness later on. By the way, the pushing down of emotion, what's the word that we use for pushing something down? Depressing it. We all have this idea that depression is this chronic brain disease caused by genes and neurochemicals. No, it isn't. Depression begins with the pushing down of emotion as a coping mechanism. Now I'm going to quote you from the Journal of Pediatrics, which is the official journal of the American American Academy of Pediatrics. And the article is from the Harvard Center on the Developing Child, which is to say the world's leading child developmental research institution. And here's what they say in the abstract of this article that was published in 2012. Growing scientific evidence demonstrates that social and physical environments that threaten human development because of scarcity, stress, or instability can lead to short-term physiologic and psychological adjustments that are necessary for immediate survival and adaptation, but which may come at a significant cost to long-term outcomes in learning, behavior, health, and longevity. In other words, the way we adapt to childhood adversity help us survive those immediate threats to our well-being, but those same adaptations become the source of learning difficulties, behavior problems, and pathology later on. And that's what the problem with childhood trauma is that something happens, we adapt to it. We adapt to it according to the wisdom of our organism, like repressing the anger, but that same adaptation will lead to problems later on in mental or physical health. And what I'm suggesting to you in very broad terms is that the conditions that we see related to chronic pain, such as the health conditions I mentioned, autoimmune disease and so on, malignancy, mental health conditions for that matter, because there's a link between depression and chronic pain has been demonstrated in a number of studies, or issues like addiction or just chronic pain syndromes. These are related to childhood trauma, but they begin as adaptations. So I think I'll stop here and take any questions, if any.
Awesome. You know, so I'm lucky enough to have some nice training. Started in psychiatry, moved on to a fellowship in addiction, then a fellowship in pain with anesthesia. As I was working, I started realizing a lot of what you're talking about. I would have my residents and trainees coming through, and we would start talking about what do you notice that's similar, whether it's someone from addiction or someone struggling with mental health or someone struggling with chronic pain? And the one thing that we found, and all of my residents had to do assessments for adverse childhood experiences and assessments for PTSD, is that the numbers were equivalent across the board. They were higher than we anticipated. I've worked in many programs that don't even assess for trauma. So I'm curious, the question comes out on policy, but you agree that childhood trauma leads to a lot of chronic illness and maybe the vast majority of chronic illness that we see today. How do we shift policymakers to put children first and families first, rather than all the funding we put into the healthcare system we do today?
Oh gosh, here you're addressing the very nature of the society that we live in, because a lot of kids are being hurt these days, even without being abused. There's two ways that children can be, and here's where we get into what trauma is. Well, trauma is a wound, is a psychic wound. In fact, the word trauma means wound or wounding. That's the Greek origin of the word. So children can be wounded in two ways. One is bad things happen to them that shouldn't have, physical, sexual, emotional abuse, all the adverse childhood experiences, criteria, a rancorous divorce, a parent being jailed, violence in the family, parent dying, mental illness on the part of a parent being addicted, physical, sexual, emotional abuse, these 9 or 10 criteria. That's one way that children can be hurt. But children can also be hurt not by something bad happening to them that shouldn't have, but by something good not happening that should have. And that means they don't get the kind of nurturing, relational holding that they need for healthy development. The fact is, most children in society don't get that. Not because the parents don't love them, not because the parents aren't doing their best, but because the very crucible for child development never used to be the nuclear family. Throughout human evolution, and until the blink of an eye ago, historically speaking, it was the hunter-gatherer tribe, the extended family, the clan. So children had multiple adult caregivers, giving them a sense of belonging and security, and stepping in for the parents when the parents needed that support. That's what's called allo-parenting. Allo means other or change, so that other parents would come in to support the birth parents. And so children grew up in emotional security. Now that's, modern life has totally destroyed that. And especially in the last 40 years, I mean, it started before then, but the extended family, for a lot of kids, it doesn't exist anymore. People move, they live far away from their extended families. The village, the clan, the tribe, the community, it's become more and more isolated and eroded. Both parents are having to work, which is historic, but from the point of view of human evolution, is a completely abnormal situation. Children should be with their parents. I'm talking from the point of view of evolution. So in other words, evolution has prepared us to have certain expectations for health and development. Not even, by the way, even to say to have certain expectations is the wrong way of putting it. Evolution prepared us to be expectations. And here's what I mean by that. The lung doesn't have an expectation for oxygen. The lung is an expectation for oxygen. The lung developed in interaction with oxygen. If there was no oxygen, there'd be no mammalian lung or fish lung for that matter. So the lung is an expectation of oxygen. The human being is an expectation for secure attachment relationships. Now, in a society that, due to economic, social factors, has deprived children of the template for secure attachment relationships, you're going to get a lot of kids being hurt. So when you ask me about policies, if society began with this question, what would be healthy for children? We would have physicians trained to understand the importance of intrauterine stress on child development. In other words, the prevention of chronic pain, illness, and addiction would begin at the first prenatal visit. And I know I'm sort of, well, I'm not digressing really. I'm just giving you the fullest answer I possibly can to your question. I'm going to quote from you from that same Harvard article that I just cited. They talk about brain development. They say the architecture of the brain is constructed through an ongoing process that begins before birth, continues into adulthood, and establishes either a sturdy or a fragile foundation for all the health, learning, and behavior that follow. In other words, already what's happening in the womb has an impact on the child development. And we know that if you stress human beings, as happened in 9/11, and that was studied, or if you stressed animals in a laboratory, their offspring will predictably have issues with stress hormone levels and behavior problems. So if we understood all this, we would take much better care of pregnant women, supporting them so that we're diminishing stress in their lives. We would have much more support for young families. We would provide much longer parental leave, and we'd have community services to create communal interactions for parents so they wouldn't be isolated in their home. You would be much more trauma aware, and rather than punitively approaching families or children are being traumatized, we would approach them supportively, realizing that the trauma that they're passing on to their kids is simply trauma that they ingested in their own childhoods. We would do much more to undo the effects of colonial trauma in our indigenous communities, whereas you both you and I know it's a horrendously tragic situation and continues to be like that. My friend, the children's singer Raffi, he's got this concept called a child honoring society. And he just woke up with that. One night he just couldn't sleep and he woke up. And so he established this child honoring institute. Well, what if we took his concept of a child honoring society and just asked ourselves, what would it mean if children's needs, which we say are our highest values, by the way, we say that, they're our future, we don't behave like that at all. What if we actually had a child honoring society? All kinds of policy differences. Teachers would be educated in trauma. Teachers would be educated in child development. So it wouldn't be just a question of behavioral control and teaching of subjects. It'd be a question of what conditions the kid needs for healthy development. And that means what emotional conditions they need. So schools wouldn't simply be conveyor belts of information. They'd be templates of emotional healthy development in tandem with the home. So, I could go on, but we'd have a very different, not to mention the legal system that takes traumatized kids and punitively handles them from an early age on and ensures that they're going to be traumatized adults. So that's in a nutshell.
That was a great nutshell. And I've said it over and over again, and I've met with Indigenous groups across the country from coast to coast to coast, talking about, what intergenerational trauma looks like, and more so, what does a nation look like who's undergone genocide? And then we compare it to the cycles of generations of families that struggle with child abuse, mental health, substance abuse, pain, chronic illness. And I often say, if we really want to change healthcare into the future, because healthcare is going to bankrupt Canada one day, because it's just going to keep getting worse and worse and worse. If we really want to change it all, we have to put everything into the mom. Every mother who has a new baby should be surrounded with ultimate resources. And you're right, from the time of conception. And you just kind of described my whole research life before medicine. which was all on trauma and epigenetics, both in the male and female. We always blame the mom, but let's not forget that epigenetics come from dads as well. So really brilliantly put. A big question that somebody with lived experience is wondering, should somebody's trauma restrict certain types of medications? So I think this comes down to knowing that trauma and PTSD increases the risk of substance use disorders and addiction. Yet at the same time, opioids can be quite beneficial for some people who struggle with pain.
Yeah. So that's been studied quite a bit. In fact, I have a whole sheaf of studies on my desk here, because when I was working in palliative care and in family practice, that was an issue I had to deal with quite a bit. Less so in palliative care, because if somebody at the end of their lives gets addicted to opiates, well, so what? You know, I don't mean that.
No, of course.
Heartless stages mean, you know, practically speaking, that's not something you can be less concerned about. Many of the studies in those days seemed, and talking about the 1990s, seemed to indicate that the judicious and well-monitored treatment of chronic pain with opiates only in a small percentage of cases will lead to addiction. But then, of course, there's been a huge shift since the 90s. There's been the opioid overdose epidemic. That opioid overdose epidemic cannot be separated from what's happened socially. Like in the US, where last year 93,000 people died of overdoses, 93,000. The numbers are just going up and up every year. But that's also been, this is in 2019, I'm sorry. That's also been, 2 years ago, before then it was 70,000. The year before then it was 60,000. But this has been accompanied by major social economic shifts, where particularly in the white working class, people all of a sudden have lost their jobs because the industrial economy has been hollowed out due to globalization. People lost meaning in their lives. They lost the connection of work and value. And that's what my friend, the psychologist Bruce Alexander, calls social dislocation in his brilliant book, The Globalization of Addiction. So when larger numbers of people are socially dislocated, they lose connection, their value, a sense of integration, all of a sudden their pain levels go up. They develop chronic pain. And then doctors give them opiates, they become addicted. Because the same traumas that cause chronic pain can also cause addiction. Mm-hmm. So it's a really important question. So here's my answer to it. Nothing works out of context. So if I see somebody with chronic pain, just as if I see somebody with addiction, I'm not just interested in their physical problem. I'm interested in the whole biopsychosocial context in which developed the problem. And there was a recent study published in the Journal of the American Medical Association, sorry, the JMA Psychiatry by Howard Schubener, whose name may be known to you, and colleagues. And they talked about, they looked at chronic pain patients and they gave them an intervention where people were educated to understand that the chronic pain doesn't represent a dangerous physical noxious stimulus anymore, but it was like a chronic programming of the brain. That intervention alone caused significant pain reduction that in a year-long follow-up was still present. In other words, chronic pain has huge psycho-emotional components to it. So therefore, if somebody came to me with chronic pain, I would neither refuse them to give them opiates if I thought they really at the moment needed it, but I would not stop there either. I would say, well, let's look at the larger issue. And I believe that as long as I had a good therapeutic relationship with them, and there was mutual trust and they felt understood, I think I could deal with their pain chronically, eventually get them off their opiates. That would be my approach, if opiates were required.
Yeah.
You know,
Well,
I'm not talking about a walk-in clinic where some stranger comes in
no,
and says,
of course.
I'm talking about there's a relationship, a therapeutic relationship.
I love, Johan Hari's that opposite of addiction is that relationship piece.
Yeah.
I'm a big believer in all of medicine. That is our role, is to provide relationships, to provide, that healthy banter back and forth of what healthy relationships can look like, what healthy boundaries can look like. And I'm a big believer that access on demand for trauma therapy has to be a big piece to this. And that a lot of the times this is treatable. But I love your answer. I'm not going to restrict based on anything. I'm going to base everything on my relationship. And whoever asked that question, I hope you understand that is everything we're trying to do here at the PSA. I know that Christelle had a question about anger.
Yeah, sure. We have a couple of questions, Dr. Mate, regarding that. I'd like to loop back, though, to the therapeutic relationships in a moment if we have time too. So firstly, regarding anger, you mentioned that the repression of unhealthy anger is a risk, and you said a risk.
Sorry to interrupt, the repression of healthy anger.
Oh, my apologies. That's what I meant to say. Forgive me. Let me clarify. Thank you for checking me on that. Repression of unhealthy anger. Thank you. Is a risk. You said you were going to elaborate a little bit later on that risk. Could you briefly just speak to what those risks could specifically be at this moment?
Sure. So in the study of ALS patients, amyotrophic lateral sclerosis, which is a whole other really interesting subject, the commonest, I've studied that issue. People with ALS have severe repressed emotions. And even the neurologists, there's been studies in neurological journals about how neurologists always find ALS patients extraordinarily nice. This is a common knowledge in neurological circles. They don't understand the connection, but they certainly notice it. And in one particular study, ALS patients that expressed anger, they lived longer than the ones who didn't. In other words, anger isn't simply an emotional abstract event. I mean, think about it. When you're angry, forget the content of what you're angry about. Check in with your body. If I were to assault you and you mounted a healthy rage response, it wouldn't just be an abstract event in your head. There'd be a full body physiological reaction. You know how much energy it costs to repress that? And the repression of anger, we know, suppresses the immune system. It suppresses the activity of a group of cells called natural killer cells that are important aspects of our immune response to malignancy, for example. So the repression of healthy anger, when you actually think of the physiology of healthy anger and Dr. Panksepp's concept of the rage system in the brain, and you repress all that, oh boy, you're stressing yourself. Not only are you stressing yourself, you also make yourself a sitting duck for more stress. Because if you're somebody who doesn't know how to protect your healthy boundaries, you get tread upon all the time. You get invaded all the time, emotionally and perhaps even physically. And so that's also stressful. And stress, as we know, is not simply a psychological event. It's got all kinds of physiological dimensions to it, including activation of the hypothalamic pituitary adrenal axis, stress hormones, so on and so forth. So the repression of anger is itself stressful, and it invites more stress. So no wonder it leads to more disease. Healthy anger I'm talking about. Now, maybe implied in your question is the distinction between healthy and unhealthy anger. So here's the thing about healthy anger. If I were to now insult one of you here, and you say, you can't talk to me that way, I will not allow that. That'd be healthy anger. It's a boundary defense. And as soon as I backed off, there'd be no more reason for it. It'd be over. It's in the present. It serves its function. It's gone. Unhealthy anger is usually repressed anger that erupts from you. So, somebody accidentally steps on your foot and you go into a rage. Why? Because you've been carrying so much repressed anger. It's like a pressure cooker all of a sudden. And it's not over when you express it. In fact, unhealthy anger, if you notice it, if you ever raged like I have, you'll notice something. The more you rage, the more rageful you get. So rather than expressing itself and then it's gone, rage circuits more and more, rage recruits more and more brain circuits and gets worse and worse, which means that your blood pressure goes up, your adrenaline levels goes up, your blood vessels narrow, your clotting factors go up, bang. That's the type A personality that over 100 years ago, the Canadian physician William Osler said was prone to have heart disease. So there's that. So unhealthy anger is not based on the present, and it doesn't exhaust itself once it's expressed. In fact, it gets worse and worse. That's the distinction.
Really appreciate how you naturally went into what unhealthy versus healthier anger could be, because also someone did ask that question too. So I think it's important to build on that. And if it's okay, if time would permit, I'll move into one more question regarding the therapeutic relationship, building that trust, mutual trust. And so someone asked, and commented that opening old wounds can be so difficult, especially if we aren't aware of them. And so how can someone with chronic pain or persistent pain or illness and childhood or early adulthood trauma begin to move from repression and suppression in a way that also supports healing and pain management?
So opening of wounds, of course, is a metaphor, but it's a good one because, as I said earlier, the word trauma itself comes from the Greek phrase for wound. Let me ask you this question. If you had a wound that to receive proper treatment, that wasn't healing properly, and therefore to receive proper treatment, you had to go to a really skilled surgeon so he can open up the wound. Would you not want that?
Yes.
But wanting that would depend on your trust in the surgeon and your trust in the process.
Right.
And so it all depends on the therapeutic relationship, just Christelle, just as your question implies. So if there's a trusting, compassion-based relationship, I'm not worried about people experiencing pain when they talk to me. Because the pain is already there. I'm not causing them pain. The pain is already there. The pain is repressed, it's already there. It's the repression of pain that's causing their suffering. Pain and suffering are not the same, by the way. And sometimes it's necessary to feel the pain. In fact, you know what? Nature created us so that we will have pain because the pain is protective. Not to feel it is not protective. So in my experience, when people feel safe, they're grateful to feel their pain that they've repressed all those years. Because all of a sudden they feel more real, they feel more themselves. Now they feel they have something to work with. So I'm not worried about, it's not a question of going in there brutally and ripping open old wounds. It's a question of establishing a relationship where that conversation can be had. And that depends on a lot of invitation on the doctor's or the therapist's part and a lot of willingness on the client's part. So it's never abruptly just going in there. I mean, no surgeon should operate on you without your permission. unless of course you're unconscious and your life is in danger, you know. So I'm saying is that in the context of a proper relationship, the experience of that pain that you're opening up is actually beneficial, and people are grateful for it. That's my experience over and over and over again.
Thank you for that. Would you like to move towards speaking for the last half an hour?
Sure.
Thank
Well,
you.
Let me then, let's see if there's anything more I have to say here. Well, so when it comes to chronic illness, whether it's fibromyalgia or debilitating autoimmune diseases like lupus, I could show you a picture that's on my laptop here, on my desktop. It's a woman in London with systemic lupus, SLE, a debilitating, potentially life-threatening autoimmune illness. Young woman. I gave a talk somewhat along similar themes in London 2 years ago, 2.5 years ago, and she was at the talk. And of course, what I said about childhood trauma and repression really resonated with her. So she began to see therapists to deal with it. She sent me a photograph a few months ago of her fingers. She's not on any medications anymore, by the way. And I know so many people who've been told by their clinicians that you'll be on this medication for the rest of your life and you'll never be free of your disease, who actually are free of their disease and are not on medications anymore. I'm talking about people with scleroderma. I'm talking about people with SLE, with rheumatoid arthritis, and so on. And anyway, I could show you these pictures. Her hands, her fingers, because of Raynaud's phenomenon, which is a condition that affects the blood supply to the fingers. It's a feature of many autoimmune diseases, including potentially SLE. Her fingers were white. She sent me a picture of before and after. Her pictures are just suffused with blood, pink and lovely. This is without medication because she dealt with the emotional issues. Now, this would seem, well, my medical colleagues would say, well, that's an anecdote. It doesn't count. It's anecdotal. Well, I believe in anecdotes. I believe in people's stories, if I can verify them. I can show you pictures of a woman with scleroderma. Scleroderma means hardening of the skin. That's the Greek. Derma, skin, sclerosis, hardening, hard skin. She was like this because her soft tissues were hardening. That's what scleroderma does. The anti-inflammatories didn't work, the immune suppressors didn't work, the steroids didn't work. She just wanted to die. She could not get out of bed by herself without assistance. She was wheelchair bound. She's now walking around. She's not on medications. She's writing her autobiography. I checked with her physician in Boston. It's all true. There's a couple of books whose authors I spoke with. One is called Cured, The Science of Spontaneous Remission by Dr. Jeffrey Rediger. Rediger is a physician and psychiatrist at Harvard. He's a medical director at McLean's Hospital. This book documents medically proven cases of spontaneous remission of people who were supposed to have died already, but not only did they not die, their disease went away, whether it's so-called terminal malignancy or autoimmune disease like pulmonary fibrosis. So Jeffrey did what I did, but he did it more systematically. He said, why don't we study the people that get better without our treatments or despite the failure of our treatments? These are the people we should be studying, which of course is obvious. But interestingly enough, he found, as I found, is that these people that get better defying our prognostications, the doctors never want to know why. They never ask, what did you do? I've known several of such cases. And there's another author, Dr. Kelly Turner, who's an oncological psychologist. And she wrote a book called Radical Remission, where she also studied people who get better when they're supposed to have died. Now, the common feature that I found in these clients, like this SLE patients I told you about, like the scleroderma patients, like cancer patients I know, like the ones that Jeff Rediger and Kelly Turner studied, you know what they have in common? They radically reconfigured their relationship to themselves. They stopped repressing themselves. That's what they did. Now, they did also other things, supplements, diet changes, yoga, meditation, spiritual exploration, all kinds of things. But the common feature is that transferred relationship to self. Now, you might ask, well, why? It's very simple. That suppression of the self is what caused the disease, is what potentiated the disease in the first place. I don't want to say cause, because cause is a complicated thing. There's never just one cause, but this is a potent contributing factor in every case. When you turn that around, your physiology changes. Why does your physiology change when your emotions change? Well, that's obvious, because emotions are physiological events. And you can separate the mind from the body. And there's Dr. Candace Pert, great researcher who found the opioid receptors, wrote in her autobiography or under autobiographical book, the mind and body. She called it body mind. Body mind is inseparable, so that scientifically we know through the study of what's called psychoneuroimmunology. If you really want a tongue breaker, you'll call it by its full name, psychoneuroimmunoendocrinology, which simply means the study of the interaction, the unity, inseparable oneness over emotional apparatus, the psyche, the immune system, the nervous system, and the hormonal apparatus. So every time you get angry or you repress anger, every time you feel love or you feel the lack of love, those aren't simply emotional events. They have physiological implications, manifestations, because it's all one system. I mean, just look how your gut feels when you're upset. It's because your vagus nerve gets really activated. There was a study here I have in front of me. Viewing pictures of a romantic partner reduces experimental pain. Looking at a picture of the one you love reduces the pain that you have. That's not an abstract event. Something's happening in your body. This is all one. And this is where I really think that medical education is just utterly lacking, because this research has been done, 10,000 papers, and I underestimate, have been published on this stuff, the mind-body unity and its implications. It's not taught in the medical schools. So the average physicians would listen to me and say, this guy's talking mumbo jumbo, except I'm talking pure science. So that's why turning around our emotional relationship to ourselves can actually have a tremendous physiological impact on our bodies. Let me stop there again and see if any, because I'm going to go and talk about something else now. So I just wanted to complete that part. Any questions on what I just said here?
I think it's brilliant. I can see why you get pushback from the medical community at times. I'm obviously have felt it before as well. You know, there's a ton of questions that people always have. How do I heal my childhood trauma? How do I, you know, as mentioned, how do I open those wounds? How do I treat this? And, you know, I've always been a believer in trauma therapy. You mentioned some of these these authors. Dr. Alan Abbas out in Halifax was doing intense short-term psychodynamic therapy with chronic pain patients, and it seems the only way we get any sort of buzz is when CBC picks it up, or the Globe and Mail, or and it, you know, people are blown away. Oh my goodness, I don't have pain anymore because I dealt with everything that was going on. You know, in our deprescribing program, we took everyone off of their meds and provided trauma therapy and skills-based therapy, and saw many people get much, much better. In fact, some people with no pain left at all. How do we bring the researchers in? How do we get the universities and the systems to start to listen that, you know, simply building clinics, putting a bunch of people inside of them and still using needles and injections and focusing on purely a biomedical protocol isn't the answer for these individuals, for many of these individuals. For some, you know, we got to remember personalized medicine, but how do we shift the whole thing? And I know you've basically dedicated your whole life to this, but what do we do at that policy? I bring it back to policy. How do we get the medical schools to change?
Well, so first of all, just to reinforce something you said, we're not throwing out the baby with the bathwater here. I'm somebody who's had back surgery. I was grateful for it. That's because I had a bulging disc in my lumbar spine. It caused terrific leg pain. I lived with it for 6 months. Finally said, heck with it. Went to the neurosurgeon. Day after surgery, the pain was gone. However, that's a rare example. Most people who get back surgery get it for useless reasons. And I'll talk about that later. So, but anyway, I'm not, and you are not, debunking the value of medical intervention. Sometimes it's absolutely miraculous, as we know. We're talking about chronic conditions here, however, where medicine is pretty hobbled in its capacity to help people. But part of it is, you know, like what you're asking is, why doesn't this stuff get through? Now, let me tell you something. The New York Times had an article last week by their veteran health reporter, Jane Brody. And Jane Brody discovered this American physician who saw that there was a relationship between depression and breast cancer, and that women who were more depressed, they died sooner of their breast cancer. Big news, right? Reported in the New York Times. In 1870, James Paget, in his textbook of surgery, talked about the relationship of depression and breast cancer. And Galen, who's a Roman physician in the 3rd century, he talked about it too. So when you're asking me how to change the medical schools, well, I'm asking you, given all this clinical insight that's been around for literally hundreds of years, why does the New York Times then have this breathless article about, oh my God, we discovered a relationship? They keep reading. In writing my new book, whose title you mentioned, I collected 25,000 articles. I mean, I really did my work. I found a bit of astonishing research. Now, this is, I hope you're all sitting down. If anybody listening here to me is not sitting down, sit down. This is going to astonish you. They did a study. You know what they found? Grandmothers are good for grandchildren. Now, isn't that astonishing? And not only that, they also found out that the closer the grandmother lived to the grandchild, the better for the grandchild. Now, isn't that astonishing? How many PhDs did it take to figure that one out? In other words, what I'm saying to you is that we were discovering this stuff about prenatal, the impact of prenatal stress. We now have ultrasound scans and hormonal studies and blood tests and fetal heart monitoring to show the impact of maternal stress on the infant in a utero. I once went to an indigenous community in Vancouver Island, and I gave this talk, you know, presenting all this brilliant modern information. And this fellow came up to me and said, you know, in our nation, it was a rule. If you were stressed and upset, you weren't allowed to go near a pregnant woman because we didn't want you passing on that stuff to that baby. So you're asking a hair-raisingly, and it's the kind of question that wants me make my tear my hair out. Why doesn't this information penetrate the medical schools? Well, I think there's good reasons for that. Number one, just the obvious ones. I'm not listing them in order of importance. A lot of the medical research is funded by pharmaceutical companies. There's not much money to be made in helping people deal with trauma and stress from a pharmacological point of view. In fact, it obviates the need for pharmacology. So why would they fund it? But who's got the money to fund research? They do. So a lot of the information we get is funded by people who have a natural interest in that research because it's how they make their money. Number one. Number two, who goes into medical school? Well, pretty driven people very often who ignore their own traumas and their own stresses. They have a high rate of depression and suicide and so on. I don't know if you don't, some of the audience some may not know what telomeres are. Telomeres are DNA structures at the end of chromosomes. They're like the glue at the end of a shoelace. It keeps it from unraveling. When we're born, we have about 10,000 units of this telomeres. By the time we die, we have about 4,000. In other words, the shorter the telomeres get, the more aged we are. But not only chronological age, but also stress can shorten telomeres. And so telomeres are a marker of of biological age rather than chronological age. Black American women are 6 years older in terms of telomere length than white American women. Is that a biological problem? Or is it a social, political, economic problem showing up in the biology? This is how inseparable everything is. Now, medical students, the telomeres have been studied. They shorten much faster than those of other people their age because of the stresses of medical training. And so people that go into medical school tend to be people who repress their own trauma and they're driven, like, I don't know what your experience was like, Rob, but I was a driven workaholic doctor. And even now it's a real issue, So we tend to ignore our own stuff. How we recognize in our clients, and then nothing in our education. And so that this stuff, it's like this, we don't have receptors for this stuff. I've talked, and so I've talked to people like Bruce Perry. Bruce Perry is a leading child psychiatrist, trauma researcher, head of the Houston Trauma Academy, has just written a best-selling book with Oprah called What Happened to You. She's also written a book called, two books of Bruce Perry's that I'd recommend. What Happened to You, the one he just wrote with Oprah on childhood trauma. Another book, more substantial, called The Boy Who Was Raised as a Dog, on childhood trauma. Bessel van der Kolk, trauma psychiatrist, whose book, The Body Keeps the Score, has been a New York Times bestseller now for a couple of years. My books that have been published in, over about 30 languages, bestsellers. Vince Felitti, who did the adverse childhood experiences studies. He's an internal medicine specialist from San Diego, California. I've talked with these guys. And I used to ask them, well, how do doctors respond to you? And until recently, they all said, we talked to medical audiences. This happened to me in Calgary. I spoke at Calgary's Children's Hospital at Grand Rounds. And that Harvard article I quoted? It just came out. And I said, okay, hey, you know what? I don't have to keep yammering at you guys anymore. Here's this article in your own journal, a pediatrics journal. And I talked about the relationship between childhood stress and asthma and illness and ADHD and all that. And my experience was just like the experience of van der Kolk, Felitti, Bruce Perry. Dead silence. It's not that people argued with me. I said, you're wrong, and here's, or it's not that people said, oh, hey, this is interesting, they just sat there silently. Nobody put their hand up to ask a single question. And finally, after couple of minutes of silence, somebody put their hands up and said, well, if this is true, what are you supposed to do about it? That's the wrong question. The right question is this true? And then you go to work and figure out what you have to do about it. But it's like, and that silence and that kind of sullen passive resistance was the experience of all these other guys as well. Now that's changing somewhat. And thanks to people like yourself who are active in the field, and Hart Schubiner and other physicians, you know, many, this knowledge is beginning to penetrate. But it's really slow. And how do you make the medical schools do it any faster? I have no idea. You know how political medical schools are. Everybody's got their own little number of lectures and their little niche, and nobody wants to give up 1 minute to anybody else. It's a difficult system to penetrate. So I don't have any, I'm just laying out how it is and why it is the way it is. But I don't have a really good answer about how to make it happen, except you keep doing what I'm doing, and this organization keeps doing what it's doing, and I keep doing what I'm doing. And we have some trust that since we're speaking, we hope, well, I'm pretty confident I'm speaking truth here. I just have no trust that eventually it's going to get through. I don't have any other answer.
I think that, you know, best-selling books everywhere, refuting what we tell people in clinics, in and of itself is telling you something.
Yeah.
That we can do better, we should do better. And it shouldn't be, is this true? It's okay, it's published, it's been talked about for generations.
Yeah.
Now let's figure out what to do. Beautifully said. We have to figure it out. We have to make our systems more holistic, more person-centered, more about that individual, and quit saying, what did you do? And start saying, what happened to you?
Yeah.
And let's get to the root of that. And let's deal with it. And that's, you know, I think trauma-informed care is a really important piece when we put it into a big system, but it's got to go beyond the healthcare system. It has to be the society as a whole. Because if someone doesn't get triggered in your clinic, but they go to 7-Eleven and get triggered, and Safeway and get triggered, and you know, they're going to get triggered everywhere else. We have to actually look at how do we treat and resolve and work with individuals. Imagine how much money we could save in our health spending.
Oh yeah, I think that take something like PTSD. By the way, there was a study, this may astonish some of your listeners. It was published in the Journal of the American Medical Association. It came out of Harvard either 2 or 3 years ago. The more severe symptoms a woman has of PTSD, the higher the risk of ovarian cancer.
Yeah.
And those with the highest level had double the risk of ovarian cancer. The less severe the symptoms, the less the risk. Now, if that was the only study ever done on the mind-body unity, that should have been enough. Published in a major journal from Harvard, for God's sakes. Do you think the average gynecologist even read it? Do you think the average gynecologist even asks a woman? Now, why is it significant? Because we know that dealing with those emotional issues can actually improve the outcome. You know, and so I forget what you were saying that triggered me to say that. I'm just saying that the evidence just keeps coming in and coming in and coming in. It's no longer a question of, is it true? And you mentioned trauma-informed care. So what does that mean? It does not mean that everybody has to be a trauma specialist or trauma therapist. But if I'm a physician and somebody comes to me with migraine headaches, chronic pain syndrome like migraine headaches, and if I know that migraine headaches research has significantly linked to childhood trauma, which it has, but the average neurologist doesn't know that, then you will not simply prescribe the medications to stop the dilation of the arteries that is the mechanism for the migraine pulsating pain. You will not simply give chronic prophylactic medication, you'll also say, what are you repressing here that your headache is expressing? And I'm not necessarily the expert to help you deal with that, but can I send you to somebody who can talk to you about that?
There it is.
And so that's all it means to have trauma. Trauma-informed care doesn't mean that everybody has to be a trauma expert. It does mean that we're informed about trauma. Same thing in schools. When a kid is a bully and we have these zero tolerance policies. Well, I did a major search on bullying because I was going to write a book on bullying and I never got to doing it, lack of time. But there was one research paper that summed it up: zero tolerance, zero evidence. But every school board's got zero tolerance policies. And basically what we do with bullied kids is we exclude them. Now, these kids are traumatized kids. Exclusion makes their trauma worse. So if we're trauma informed in the schools, we would not exacerbate the trauma. We would find other ways, inclusive ways of dealing with it. So trauma informed could apply right across the society. Now, saliently in medical care, I know what I was going to say about PTSD. It's tremendously expensive to treat PTSD for a lifetime. And it's inefficient the way we're doing it. We're medicating people with long-term medications forever. And what if we actually understood PTSD and dealt with the childhood trauma template of it and help people to work through that trauma by whatever means there are, and there's some good methodologies now. We would save a whole lot of money. So this is what triggered this little rant on mine, is when you talked about saving money. We would actually be saving money. I mean, if I could treat somebody with rheumatoid arthritis through a mind-body approach, and if the disease went into remission, as I got X number of examples of, and have been studies on it as well, I'd be saving the system a lot of money.
Absolutely. Absolutely. And you know what? I love that you brought up the cost of trauma therapy. So the newest studies are showing that we can completely resolve PTSD in 3 to 4 weeks with intensive trauma therapy, where you go in every day or every other day during that 3 to 4 week period. Started in Europe with veterans, shifted into the VA now in the US. We see new treatment protocols like accelerated resolution therapy, which shows complete resolution of combat PTSD in those who are living without a home and struggling with addiction, where also those aspects resolve in 3 to 5 sessions.
Wow.
And so we've seen now a novel approach, and this is where research really needs to go. How do we make trauma therapy accessible? How do we make it free? And how do we make it fast? And right now there are new programs coming out doing that. And I have some conflicts here, so I'll stop there. But at the end of the day, that's what we need to do. Free, fast, and really cost adverse to no one. The system always looks at it like it's too expensive. And then the next thing is get over the fact PTSD is not palliative. It is treatable, and it is not a medication that's going to treat it. And I hear this, I'm getting stellate injections. Oh my goodness, for something that's treatable. I'm loaded up on medications, and they got this for this sleep. Well, we have dream protocols and therapies that treat that. I'm getting loaded in that medication. I don't know if it's working, but now I have no sexual libido. I feel no happiness either. I'm also no dullness, but shifting out of the biomedical protocol. You said it brilliantly. And look, pharmaceuticals have changed so many people's lives in so many positive ways, but they are just one piece of a puzzle. And a human being is a puzzle, not a single entity of just one. And if we could shift that.
Well, 2 things. One is I'm very interested to hear about these studies you just mentioned. There's also, as you know, there's also research with psychedelics, MDMA,
Yes.
specifically in PTSD, and really positive results. And as far as medications are concerned, you know, I've taken medications myself. Like in my 40s, I was depressed, really was depressed. I didn't know how depressed I was until I was no longer depressed, you know, and that was after I took fluoxetine. So I'm not speaking against medications, but they're not the answer, because they deal with symptoms. They don't deal with causes. So
that's it right there.
It's not a question of do we give medications. It's a question of what else do we do? And unfortunately, most of the time, we don't do anything else. We just tell somebody, oh, you'll be on this for the rest of your life. Well, or for a long time. It doesn't have to be like that. I don't take antidepressants anymore. I haven't had to for a long time. In fact, when I was writing my recent book, I kind of went into a panic. 25,000 articles, 300 interviews, 100 books. How am I going to get this done? You know, and I really thought I wasn't up to this. And I started kind of panicking a bit, not panic episodes, but real anxiety. My blood pressure started going up. I thought I tried the fluoxetine again. All I got was side effects, no benefit. I stopped very quickly. I wrote the book without them, you know, but in my 40s, that really did help me. So yes, I'm totally with you. They can be beneficial. In some cases, they can be life-saving, but they're never the answer.
That's it there. You know, there's symptom management. We are a part of a healthcare system that's very good at picking dandelion heads, but not very good at getting rid of dandelions.